Next speaker is Dr. Dona and Mathew on external DCR tips and tricks. She's a consultant of oculoplasty in Little Flower Hospital, Angamali. Dr. Dona, please.
Good morning. So I'll be presenting on external DCR tips and tricks. So this was first introduced by Totti in 1904. This is the most commonly performed oculoplastic surgery. In fact, this is the bread and butter of the oculoplastic surgeon. In this, we do a bypass connection. So we create an anastomosis between the lacrimal sac and the nasal mucosa by a bony opening. That is the ostium. So here we can see the normal pathway is blocked. Then there is a connection between the sac and the nasal mucosa. That is the DCR surgery, a bypass surgery. Advantage is it is a 95 to 98% success rate is possible with the surgery. It's usually done under local anesthesia, and we have better visualization of anatomy, and it's a relatively short duration surgery, and the scarage is minimal. History. So time of onset of the symptoms are very important. Check what is the duration of the watering, what is the type of a discharge, whether it is a just water discharge, or is it a purulent discharge, or is it a bloody discharge. Always ask the patient for the history of previous surgery. Sometimes the patient may not voluntarily tell us, she might forget. So when we go in, we might have in a catastrophic stage and rule out history of trauma. Always rule out the functional cause of epiphora. So already Dr. Indu has elaborately covered on the functional cause of epiphora, but I would like to emphasize on the punctum. So always see for the punctum, punctal stenosis or atresia. So in case you want to do a DCR with intubation, the punctum is very important for the passage of the lacrimation tube, and then get a proper inference of from probing and irrigation. If the patient has a Roplas positive and you have a purulent discharge, well, that's a very good case to go with. So contraindication is acute infection, like in case of an acute acrocystitis or a tumor. In such cases, we don't open the nasal mucosa, as it can migrate, cells can migrate to the nasal cavity. Rule out nasal pathology. If indicated, do a intranasal DCR endoscopy. Then bleeding disorders and bicanalicular block, these are all relative contraindications. So a thorough pre-operative workup is very essential and indicated. Always go for a CT orbit, get a hypertension and DM control, stop anticoagulants, especially clopidogrel. So nasal packing is usually done with 2% lignocaine soaked with adrenaline. Local anesthesia, we use a mixture of 1 to 2% lignocaine, bupivacaine, along with adrenaline. So the nerves of interest is we need to block the infratrochlear nerve, then the infraorbital nerve, and the external nasal branch of anterior ethmoid nerve. So these are the area of interest. If you have a good anesthesia, then you have a happy patient and happy surgery. So let's go into the video of how to do this. So this is an infraorbital nerve block. So 2 millimeter down the orbital margin, we give the block. Then we tilt the needle and hit the lacrimal sac. Infratrochlear nerve block. Then we do a peribulbar block. Then we tilt the syringe, hit the lacrimal sac. Then we inject while we are this block of the anterior ethmoidal nerve as well. So incision, where do you start? We do a curvilinear incision along the anterior lacrimal crest. So when you do the incision, keep it 3 to 4 millimeter from the medial canthus. So as the angular vein is 8 mm from it, and suture of Notter that lies anterior to the anterior lacrimal crest. Any bleeders, please coagulate and move ahead with the surgery. So blunt dissection of orbicularis is done to reach the anterior lacrimal crest. Why do we do that? Because the canaluculus travels through the orbicularis, and if you cut it, you can damage the canaluculi and the patient can watering post-op. So medial lacrimal ligament is identified, and then I usually cut it for better exposure of the ostium to make a better ostium. So periosteum along with the anterior lacrimal crest is incised, and the periorbita and the lacrimal sacs are retracted medially. Then the ostium is created. So where do we start making the punch? So we usually begin at the maxillary lacrimal suture. Here we can see the thin grain line. That is the maxillary lacrimal suture. The first punch is done there. Then superiorly we go around 5 mm above the common canalicus, and anteriorly 4 to 6 mm beyond the anterior lacrimal crest. Then inferiorly up to the sac nasolacrimal duct junction. And posteriorly we need to remove the total sac. So opening of the lacrimal sac, once the ostium is done, we need to tend the sac with the probe with the side port. Once the sac is tend, incise in an H manner and lift the sac flap. And always evade the flap and see whether you see the mucosal lining. Then ensure free pass of the probe once the sac is open. Then the posterior flap of the sac is removed or trimmed off, otherwise it can lead to some syndrome. Then the nasal mucosa flap is raised. So now we have to suture the flap. So always trim the flap, make a taut suture and keep it tighten up. Then the flap is anchored to the orbicularis and the skin is closed in layers with 50 vicryl. So a video of this. Make a curvilinear incision along the anterior lacrimal crest. This is how we do the blunt dissection with the tenotomy suture. Now periosteal elevation is done with periosteum elevator. Medial palpebral ligament is cut. Now we are retracting the periosteum along with the lacrimal sac and now clamping the lacrimal sac with the forceps. Now you identify the suture line, that is the puncturing the lamina papyracea. So first punch is done. So that's where we begin making the ostium. So now anterior lacrimal crest is punched off. So now you can start seeing the nasal mucosa. So you know you are in the right plane. Then take off the superiorly punctured off the bone. Then once the ostium is made and you feel aggregate, do the probing. And tend the sac with the probe. Now incise the sac in H-shaped pattern and raise the flap. So you have the flap and posterior part, the remnant of the sac is removed. Don't keep it, just remove it off always. And do the probing. Ensure free passage of the probe from the lower as well as the upper punctum. Now you have the nasal mucosa there. Now we are making the, we always give it a little bit of anesthesia with adrenaline to blanch the mucosa. Then we make an H-shaped flap from the nasal mucosa. So the flap is raised. Always make large flap. Whether it is nasal mucosa or the sac, always have a thick large flap. Now we are suturing it with 50 vicryl. So once the suturing is done, it should be like a taut flap. So once the flaps are done, now you are anchoring it towards the anterior, that is the orbicularis. So the flap stays elevated from the ostium and the passage is free. Now the skin is closed in double layers with orbicularis sutured separately and the skin sutured separately. So post-op care, we usually give oral antibiotics and steroid, nasal decongestant and topical antibiotics. Follow-up is done usually after 2 weeks, suture removal after that. So usually we don't encounter any much of recurrence with DCR as it is a failed success rate is very high, and we see the anatomy and we really anastomosis, and rare chances are there is a fibrosis which happens later on at the site of ostium, or a membranous obstruction at the site of ostium, or when we have foreseen the canalicular obstruction and go ahead with the surgery. These are the cases where we encounter failures. So this is the scar. Talking about an external DCR scar, see, we don't see much of any scar. These are the post-op pictures of patient. The scars and aesthetics is very good. So what I have to say is hit the nail right at his head. So it's always difficult to do a repeat surgery. So always try to get the first time. So thank you.
Thank you, Dr. Dona, for that beautiful coverage on external.